And I would like to introduce our third speaker, Dr. Luc Foubert. He's one of our senior cardiothoracic anesthesiologists at our center. He has previously worked at Papworth Hospital, Cambridge, and also at Ghent University in Belgium. He received his PhD on inhaled nitric oxide and has a special interest in pulmonary hypertension and right ventricular function. And he will discuss today perioperative transfusion triggers, guidelines versus physiology. Luc, the floor is yours.
Thank you, Stefaan. Good evening, everybody. I have the difficult task, I guess, to come to a conclusion of what sort of hemoglobin level we would tolerate in our patients. Now, my presentation will touch on two important papers. I think one was published in the JAMA, and it was clinical practice guidelines from the American Association of Blood Banks, where they looked at the general patient population, and they looked at two important issues. What are the transfusion thresholds? And is there something wrong with red blood cell storage if it would take a longer time than normally is used normally? And then the second paper is a somewhat younger paper from 2021, when where they specifically looked at the cardiac surgical patients, and they looked at the transfusion triggers, and they came up with some interesting recommendations, which I will highlight later on in the presentation. And then, to be a little bit annoying, I took the liberty to do some physiological calculations. And obviously, as the previous speaker already mentioned, hemoglobin, but especially DO2, are probably important things to look at. And I was very interested to use these calculations to see what clinical impact of a so-called acceptable anemia would be. But first, some history. Being one of the older people around here, I was trained in those days with the 10-30 concept, hemoglobin 10, hematocrit 30. When a patient had a hematocrit of 30 in my days, the patient was doing well. This dogma comes from 1942 and remained a dogma for more than 50 years. And it was only in 1999 that they came up with a paper in the New England Journal where the 10-30 dogma was challenged. And they looked at about 800 critical care patients, and they compared a transfusion trigger of 7 grams per deciliter hemoglobin with one of 10. And their conclusion was that restrictive blood transfusion is at least as effective as, and possibly even superior to, a liberal strategy. But this is an important thing to see. The possible exception might be acute myocardial infarction and unstable angina. And to tell you something about the rest of the presentation, this is something that will come up all the time and leaves us with a lot of problems to draw final conclusions. Now, the goal of red blood cell transfusion in clinical practice should be that, first of all, you would optimize clinical outcomes, of course, and you would avoid transfusion if it is not indicated. Now, the thing that is always the argument that is always used is maybe blood is not as safe as we think. Now, I would like to be a bit provocative, because if you look at the problems with blood transfusion, febrile reaction is certainly something that is rather frequent, but is probably rather mild as an impact on the patient. Allergic reactions, some of them may be serious, but most of them are quite benign. Transfusion-associated circulatory overload in these days should not be an issue anymore. We have means enough to counter that. And so the first important one is Strali, and it is only 1 in 12,000. And you come to the very dangerous ones, namely the infections, you see what the risks are. So in my mind, we should not overestimate the role of possible side effects of red blood cell transfusions. Now, let's go to those papers. So that the first one I mentioned looked at 31 randomized controlled trials that included more than 12,000 patients.